Sumita Parmar. I am the Principal Investigator for the subject of Women's Studies. Today I am presenting to you module number 22 of this paper. This paper is Women and Health, and the module is entitled Gender and Health Policies. This paper has been written by Professor T.K. Sundari Ravindran from the Achyuta Menon Center for Health Science Studies, Trivandrum. It is important to understand the word policy and the process of policy making, because policy pertains not only to gender but touches many aspects of our lives. So what are policies? Policies are set principles, guidelines and objectives to guide activities, whether at the organizational, sectoral, national or international levels. Policy can be defined as a plan or course of action of a government, a political party or business intended to determine decisions, actions and other matters. Although policy is generally understood to mean legislation or rules made by governments, policies exist beyond these at all levels of society, ranging from international organizations to communities and even to households. Policies also exist within different sectors of society, including the private sector, civil society sectors, and religious and social institutions. So, to repeat, policies exist beyond government legislation and regulations. They exist at all levels of society, international, national, provincial, community, household, and in the public as well as private sectors. Interestingly, even the absence of a policy is in itself a policy in practice. There are de jure and de facto policies, that is, policies as stated, that is de jure, and policies as practiced, which are de facto. Policies evolve during and from implementation. So, the intended intention of a policy may not be the same as the one that is actually delivered in practice. Policies can also be made through legal court cases and through regulations. For an example, a government decision about the acceptability of a specific drug. Now, students, the purpose of this module is to provide a basic introduction to what constitute gender equitable health policies and how health policies can be engendered, that is, made just and fair. If specific health and health care concerns of women and men have to be addressed, then changes in policy are not only necessary, they are required. And not just changes in policy, but also changes in practice and changes in law. In this module on gender and health policies, we are concerned especially with public policy or policy made by governments at various levels. Government policies are not always written down as policy documents. They are often issued as government orders or as regulations and orders within departments, and sometimes even as statements of intent by heads of governments and senior government functionaries. It is important to acknowledge, as I have just mentioned, that policies are not always implemented as intended. The policy in practice may be very different from the policy on paper. Now, this may be unintentional and could be caused by practical difficulties in implementation, or it could be deliberate, resulting from opposition by vested interests responsible for implementing the policy. Sometimes the non-existence of a policy on a specific issue of importance is in itself a policy to maintain the status quo. For example, when cutting down expenditure on health, if there is no legislation or regulation protecting health services for low-income groups, it will mean that irrespective of the written policy, the de facto policy discriminates against low-income groups. Now, what are the approaches to policy and gender? Naila Kabir has categorized these into 4 parts: gender unequal policies, gender blind policies, gender specific policies, and most important, gender transformative policies. What are gender unequal policies? These are policies that privilege men's well-being over women's well-being. These are policies which directly deny women's rights. Or gender unequal policies are those that give men rights and opportunities that women do not have. For example, a policy that requires a man's consent before a woman can undergo an abortion is gender unequal. Next, we come to gender blind policies. A gender blind policy is one that fails to take into account or is blind to gender differences in the allocation of roles and resources. Such policies are not intentionally discriminatory, but nevertheless, they reinforce gender discrimination. Thus, for example, what may appear to be a good policy, like shifting from institutional to home-based care for the mentally ill, may not impact equally on men and women, because women patients may not have caregivers at home, while men patients may be cared for by the female members of the household. The next one is gender specific policies. A gender specific policy is aware of the differences in the needs, roles, and access to resources of women and men and tries to address them. However, it does not seek to change the power balance between men and women. For example, providing for women doctors to treat women patients because of strict segregation, or starting a reproductive health clinic for men. Last, we come to gender transformative policies. Gender transformative policies are those that recognize and acknowledge that there are differences of gender. They try to transform these differences through changing the allocation of roles, resources, and power equations between men and women in society. For example, men are usually reluctant to use contraception. So, raising awareness amongst them and telling them about how their refusal to use contraception impacts the health of women, and then encouraging them to take responsibility for contraception, or providing women with the financial means to access health services. Now, there are many different approaches to understanding the policy making process. According to the rationalist approach to policy analysis, policy makers are individuals with all necessary information at hand who use rational information to decide upon policy and then implement it. According to this approach, the first step in the policy process is problem identification. When an issue is identified as a problem that needs to be addressed through policy measures. The second step is one of solution development, when a range of potential solutions is developed and an appropriate policy is chosen. The third is the implementation stage, when the policy is put into practice. And last, the fourth is the policy outcome stage, when the desired outcome is achieved. In 1990, Grindle and Thomas developed a model which illustrates a variation of the above approach. According to their model, each stage in the policy process involves complex decisions. The first phase is the agenda phase, similar to the problem identification stage, when a particular issue is considered for inclusion on the policy agenda. It is only when policy makers are convinced that the issue is important that the policy making process begins. The next is the decision phase, similar to the solution development stage, when policy makers decide whether or not anything will be done about the issue at a given point in time. And the third phase is the implementation phase. Once there is a decision in favor of a policy, an appropriate policy is formulated and implemented. However, it may or may not be successfully implemented. The usefulness of this model lies in its alerting us to the possibility that the policy process can halt at any stage, not only during formulation, but even during implementation. The model also indicates that even when a policy has been enforced, the task is not complete. Continuous efforts are needed to assess policy outcome. Further modifications to policy may be needed, or more political support may need to be organized to make sure that the policy successfully achieves the desired outcome. So, we can see that in practice, the policy process is a complex process. Policy makers are often subject to conflicting pressures and demands from different vested interests or stakeholders. They may have to act on inadequate or conflicting evidence and may be engaged in struggles for power, whether through elections or within a bureaucracy. More often than not, it is such factors that determine whether or not an issue is on the agenda and the nature of policies evolved to address the issue. Now let's look at the concept of gender mainstreaming. A UN resolution defines gender mainstreaming in the following words: a strategy for making women's as well as men's concerns and experiences an integral dimension in the design, implementation, monitoring and evaluation of policies and programs in all political, economic and social spheres, such that inequality between men and women is not perpetuated. The ultimate goal is to achieve gender equality. A gender mainstreamed health policy will not be gender unequal or gender blind. It will be gender transformative and at the least be a gender specific policy. Most bureaucracies are inherently patriarchal in nature. Therefore, gender mainstreamed health policies often evaporate or disappear because they run contrary to the interests of the people entrusted with implementing them. Gender mainstreaming policy, there are three levers that can be used to gender mainstream institutions responsible for policy making. These are the awareness lever, the communications lever and the incentives lever. The awareness lever is addressing the formal and the informal norms, rules, attitudes and behavior that institutionalize inequalities within an organization. The communications lever is the timely flow of information and analysis across the system in order that all policies and programs are designed from a gender perspective. The incentives lever, this is an important one. There has been a move towards performance-based appraisal within government as part of the reforms in the public sector. Staff members are increasingly assessed on their success in achieving the goals of the government and of their departments. Gender mainstreaming requires that all performance appraisal systems incorporate incentives as well as penalties in relation to the achievement of gender equity goals. A gender perspective in health is essential to health policy because it recognizes the need for the full participation of women and men in decision making. It gives equal weight to the knowledge, values and experiences of men and women. It ensures that both men and women identify their health needs and priorities and acknowledges that certain health problems are unique to or have more serious implications for men or women. It leads to a better understanding of the causes of ill health and results in more effective interventions to improve health. And finally, it contributes to the attainment of greater equity in health and health care. The impact of poverty. In recent times, many low and middle income countries have introduced health policies specifically to protect the poor from the negative consequences of cuts in public expenditure on the health sector. Unfortunately, these pro-poor policies are also often gender blind. For both women and men, health risks and vulnerabilities related to poverty include 1. Overwork, 2. Undernutrition, and 3. Hazardous living and working environments. However, for women, these risks are compounded as they interact with the gendered roles and social inequalities of women in society. For example, within poor households, women work longer hours and have less rest because of the burden of domestic work. They may have less access to nutritious food in comparison to men. In addition, they also bear children and breastfeed them. And because of poverty and the inability to afford weaning foods, women may be forced to breastfeed for longer durations. The stresses of everyday living, childbearing, and care and catering to a household's needs within a very restricted budget contribute significantly to depression in women. Gender-based violence is another dimension of women's experience of ill health. The combination of these multiple factors can place women at greater risk of ill health than men. Not only are poor women at greater risk of ill health, they may not be able to seek appropriate health care promptly because of inequalities in access to and control over resources and in decision-making powers. They may not have the information or the time or permission from male heads of households to seek health care. Now, the construction of masculinity. Poverty and the social construction of masculinity interact to increase men's vulnerability to specific health risks. Growing up in a poor neighborhood and having to act out their male roles place adolescent and young boys and men at greater risk of violence and injuries. There are chances of high-risk sexual behavior and substance use among them. Because of their poverty, they may not be trained in any skill and have to depend on heavy manual work to fulfill their roles as breadwinners. Men may be more exposed to more seriously hazardous work environments than women. For all these reasons, it is not enough to have health policies addressed to the general population or to the poor alone. They need to be customized for the target audience. Even when an approach is woman-focused, it may not be gender transformative. For example, the women's health needs approach. This focuses on women as mothers, which is quite different from mainstreaming gender in health policies. Gender mainstreaming health policies are important for reasons of equity, for efficiency and rights. They are more likely to achieve better health for both women and men and are better equipped to meet the needs of the population. They contribute to narrowing health inequalities and promote the right to health of women and men from all sections of society. For example, a gender mainstreamed health policy would recognize espousal violence as a gender-related health problem to which women are disproportionately exposed because of social norms sanctioning male aggression and their right to control women. It would examine environmental health hazards separately for men and women and devise programs to prevent and control exposure accordingly. It would provide for active tuberculosis case finding to minimize underreporting of infection in women and also examine whether or not women's biological differences contribute to their greater vulnerability to the infection or to its consequences. Such a health policy would examine and correct gender disparities in human resources within the health sector and gender biases perpetuated by medical education. Making policy change happen. Careful and strategic planning to influence key actors and mobilize positive public opinion is necessary. Involvement of stakeholders, especially those who will benefit from the policy, and never giving up, trying over and over again. The political and social context is often hostile to changes necessary for the promotion of social and gender equity. Strategic planning is also needed to ensure that the practical conditions for implementation are in place. For example, the resources have been mobilized, alliances and networks have been formed, and the methods and messages for advocacy have been properly developed. Members of the constituency who the policy change is meant to benefit, that means poor women and men, they need to be consulted and involved in the process of advocating for policy change. It's very important to be accountable to this group rather than speak on their behalf without a genuinely participatory process of consultation. Influencing policy change is a complex process. However, with policy analysis as well as careful strategic planning, it is surely possible. There is no need to despair if an attempt to influence policy change does not succeed at a given point in time. What is needed is to wait for change in policy environment and try over and over again. Major policy changes have always needed repeated efforts. Thank you.